Sir, when you slide is ready, then just inform me. Then I'll give you one short presentation, and after that you can continue.
Yes, my slide is ready already.
Uh, Sir, because of the complaints issue, I have to record this session. So can I?
Yeah, sure, sure, no problem.
Good afternoon, doctors. Today our topic is addressing real need of Indian hypertension patients. Today our speaker is Dr. Dibjot Das. He is a renowned MD physician with diabetic and cardio practice in Agartala city. So, sir, next, floor is yours. Please.
Hello, doctors. Hello, everyone in this Teams conference right now. Myself, Dr. Dibjoti Das. I am MD General Medicine and I am practicing medicine and diabetes clinical cardiology here in Tripura. So today we will be discussing a new topic. So the topic is addressing the real need of Indian hypertensive patients. So I am uh, explaining the presentation from my laptop actually, so I'll be seeing over there, so kindly pardon me. So first, the flow of the presentation. So what we will be discussing: Indian hypertensive patients, how they are unique first of all. Next, our topic will be beta blockers and the relevance in reducing the CV risk along with the BP control. Third will be ideal partner with beta blockers, angiotensin receptor blocker, or angiotensin converting enzyme inhibitors. Which one will be better? The fourth will be the combination of beta blockers and AC inhibitors, the synergy in action, the key studies and few trials with the beta blockers and an AC inhibitor, that is specifically perindopril. And the fifth will be improving the adherence for better CV outcomes. And finally, we will summarize. So, firstly, hypertension, an epidemic in India. So, here we can see in this slide, 1 in 4 Indians. Everyone can see. Everyone is seeing the slides or not? Shubhankar, please kindly confirm.
Sir, you have to share the slide, or I can share the slide.
One second, one second, one second. I'm not sharing from my side now. Okay, then please, Shubhankar, please do it by yourself.
Okay, sir, no problem.
Will it take some time?
Just give me 1-2 minutes maximum.
Yeah, sure, sure. Everyone, I'm sorry for the interruption. Actually, I was thinking that the slide is automatically sharing. I forgot that I'm seeing it from my laptop, from my mail, actually.
Sir, is it visible?
Yes, yes, yes,
My
it's
slide,
visible.
my
Yes,
screen.
yes, it's visible. Okay.
Sir,
From slide number 3 or 4, you just move on. I'll tell you. Okay,
three.
from
Slide
this
number
slide.
three.
Yes, 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 from this slide. Okay. So what I was saying, yes, one in 4
Sir,
Indians.
after
Yeah,
after finishing, sir, just after finishing the slide, just next you can tell me, and
definitely,
I'll.
definitely, definitely. I will ping you. Yeah. So 1 in 4 Indians has a high blood pressure. So it could be you or your loved ones. So as the saying goes, that BP ghatao and life bachao. So don't delay. Get your blood pressure checked today. This is what this says. So regarding the prevalence rate is 35.5%. Out of this, 33% in the rural area, those who are hypertensive, and 40% in the urban population. The leading cause of death and disability, with a 1.6 million deaths and 33.9 million of disability adjusted life years. So to the next slide, please. So here we see that the Indian hypertensive patients are different. So there are some unique challenges. So what are these challenges? Hypertension burdens India's healthcare system, affecting an estimated of 220 million people and leading to significant fatalities from coronary heart disease as well as CVA. So, these risk and the challenges for those who are young patients, obese patients, normal weight patients with a central obesity, and that is truncal obesity, and the patients with sympathetic overactivity. To the next slide, please. Yes. So more than 62% of Indian hypertensives have a sympathetic overactivity. Here we can see a multi-center non-interventional cross-sectional pan-India epidemiological study that has been done in 1514 patients, where we can see that with increasing recognition about the role of sympathetic overactivity in the pathophysiology of hypertension and associated cardiovascular complications, it's of utmost importance to address the management of sympathetic overactivity in the newly diagnosed hypertensive patients. So, to the next slide, please. Okay, obesity, not this one, the next one. Yes. So, obesity stimulates sympathetic nervous system activity, the renin, angiotensin, aldosterone activation. So, here in this flowchart, we can see that the activation of sympathetic nervous system is directly correlated with the obesity, where we see that there is an increase in non-steroid fatty acids, there is an activation of the RAS system, that is renin, angiotensin, aldosterone system, there is an increase in leptin. It is a hormone basically that controls our body weight. And fourth, OSA and baroreflex, baroreflex, this what is called baroreflex system in our body. So insulin, there is an insulin resistance as well as hyperinsulinemia, and that finally causes some structural effects in the blood vessels, and as a result there is a vasoconstriction, due to which there is hypertension, there is sodium retention and an increased cardiac output, finally leading to hypertension. So this is basically what the flowchart is showing over here. So to the next slide, please. So next comes beta blockers, class 1 level A indications. So the European Society of Cardiology 2024 guidelines for the management of hypertension, the recommendations say that among all BP lowering drugs, the ACE inhibitors, the ARBs, and dihydropyridine calcium channel blockers, and diuretics, that is thiazides and thiazide-like drugs such as chlorthalidone and indapamide, they have demonstrated the most effective reduction of blood pressure and cardiovascular death events, and are therefore they are recommended as the first line treatments to lower the blood pressure. It is also recommended that beta blockers are combined with any of the other major BP lowering drug classes when there are other compelling indications for their use. Example, in angina, in post-MI, in heart failure, and with reduced ejection fraction. Am I visible?
Yes, sir, it's visible.
Actually, one call came. Okay, so or for heart rate control. So it is I'm repeating again. It is recommended that the beta blockers are combined with any other major BP lowering drugs classes when there are other compelling indications for the use. The specific use are those where there is an angina, post-MI, heart failure with a reduced ejection fraction. Reduced ejection fraction is when it is less than 40% left ventricular ejection fraction, or for a heart rate control. Next slide, please, Shumankar. Okay, so the next slide is beta blockers BP control with a CV risk reduction. The European Society of Cardiology 2024 guidelines, there are a few new recommendations. So these say that it is recommended to use a risk-based approach in the treatment of elevated blood pressure and individuals with moderate or severe CKD, established CVD or HMOD, diabetes or familiar hypercholesterolemia, and those who are considered an increased risk for CVD events. These are class 1 level B, and class 1 level A says that it's recommended that in hypertensive patients with a confirmed BP of 140 over 90 mm of mercury, irrespective of all CVD risk, lifestyle measures and pharmacological BP lowering treatment is initiated promptly to reduce the CV risk. That is, if the BP we see if it is more than 140 over 90 and over repeated checkings, so it is recommended to initiate the BP lowering medications along with the lifestyle changes. So to the next slide please, Shubhankar. Okay, so here we see that bisoprolol stands out amongst other beta blockers. How? First, it is superior to heart rate reduction versus metoprolol. Second, the low inter-individual variability versus other beta blockers like metoprolol or nebivolol. Third is its long elimination half-life versus metoprolol, carvedilol and propranolol. Fourth benefit is significant reduction baroreflex sensitivity against metoprolol and atenolol. Fifth benefit is high beta 1 selectivity, that is 14-fold selective in comparison to metoprolol and 2.3-fold selective, which where in metoprolol we'll see 2.5 times selective, but in bisoprolol we see a 14 times more selective beta 1 selectivity. And sixth benefit is equal BP lowering efficacy versus nebivolol. And the seventh benefit is an improved HDL cholesterol levels versus other beta blockers like in metoprolol or atenolol. Okay, to the next slide please. Okay, so here we see a schematic representation of two wheel and two brakes signs. So how it plays, how the cycle drives. So it drives via the two wheels. So one is the kidney and the other is the CNS. So in the kidneys, what it does, the renin angiotensin aldosterone system here, there is a vasoconstriction. How the vasoconstriction is happening? Via blood pressure rise, via rise in sympathetic tone, via a rise in aldosterone, via rise in left ventricular hypertrophy, and via fibrosis. And in the sympathetic nervous system, how it works, the pathophysiology, how it works, how it leads to hypertension via vasoconstriction, via an increase in RAS activity, that is all those points those I have mentioned here. Next, via increase in vasopressin, next via increase in the heart rate as well as the heart contractility. So all those pathophysiological steps, those are blocked by this drug called perindopril in the kidneys and bisoprolol in the heart. So together they are working together and controlling the dual pathophysiology activity and controlling the hypertension as well in the RAS system as well as in the sympathetic nervous system. So I guess everyone is getting the scheme clearly. Everyone understood. So next slide please, Shubhankar. Okay, so here we see ACE inhibitors, how it controls BP with CV protective benefits. ACE inhibitors are the direct cardiovascular protective effects through angiotensin 2 reduction and an increased bradykinin availability. How it does and how it affects. First, it lowers the BP. It has a BP lowering effect. Second, it's improved endothelial function. Third is its anti-atherosclerotic effects. Fourth is via fibrinolysis. And fifth is via reduced neointimal formation, as you can see in the schematic representation here in the diagram. Okay, to the next slide please, Shubhankar. So ACE inhibitors, how they reduce CV deaths, acute myocardial infarctions in comparison to ARBs. So here in this pie chart we are seeing a trial with AC inhibitor over 39. Here 39 trials have been done over 1,50,000 patients, and with ARBs 11 trials have been conducted over 55,000 patients. So here with ARBs we see that there is not such good result with at all cause mortality and CV mortality, but and also stroke and acute myocardial infarction. There is a negative rise we can see here in this chart, but in stroke there has been a benefit, quite a bit benefit. Now compared to ARBs, if we see in the trials on 1,50,000 patients with AC inhibitors, here we can see there has been a significant benefit in all the charts here, like in all cause mortality, in CV mortality, with stroke patients and acute myocardial infarction. So here we can say that the AC inhibitors in comparison to ARBs, here AC inhibitors are a clear winner. So next slide please. Yes. So AC inhibitors, unlike ARBs, have proven mortality benefits in the meta-analysis of multiple randomized controlled trials involving more than 78,000 patients data. So here is a meta-analysis of 15 randomized controlled trials of angiotensin receptor blockers or AC inhibitors versus placebo. Over 78,000 patients with stable CAD or at high risk for CAD without heart failure. 3-year median follow-up. So here we can see the same scenario. With ARBs, these are non-significant, only a slight significance in stroke patients, but with AC inhibitors, there is a significant reduction in all-cause mortality, in CV mortality, with stroke patients as well as with non-fatal MI patients. To the next slide, please. So here is a Kamit study. Basically, it's a Korean study, 2023 conducted. This study says that AC inhibitors significantly reduced all-cause mortality in more than 4,800 Asian hypertensive patients with acute myocardial infarction in comparison to ARBs. So here is a clear graph A, B, and C, where we can see the all-cause death, cardiac death, and myocardial infarction, where AC inhibitors have been proven better than ARBs. So the conclusion says that ARB therapy at discharge in hypertensive patients with acute myocardial infarction who survived the initial attack was inferior to AC inhibitor with regard to the incidence of coronary disease, all-cause death, and MI at 2 years. This data suggests that AC inhibitors be more appropriate to control the BP in hypertensive patients with acute myocardial infarction. So this is the conclusion. So next slide please. Guideline advocate for dual combination therapy. European Society of Hypertension 2024 guidelines for the management of hypertension. It says that start with a dual combination therapy in most patients. So how we will combine? First, an AC inhibitor or ARB added with a CCB or a diuretic, and we should increase this to full dose if it is well tolerated. Through this technique we will get up to 60% control in BP. Next step comes triple combination, where we can give an AC inhibitor or an ARB along with a CCB and along with the diuretic. So this triple combination increased to full dose if well tolerated. Here we can see that up to 90% of target BP is achieved. Next, for patients with true resistant hypertension in the next step, which is approximately up to 5% of the patients, those who are not controlled even though we are giving triple combination drugs. And now to consider to consult hypertension specialist in patients who are still not controlled. Consider additional therapies, drugs or renal denervation. So here, along with all these single combinations, dual combination and triple combinations, beta blockers can be used as monotherapy or at any step of this combination therapy. What the guidelines 2024 ESC guidelines say. Next slide please. So beta blockers with AC inhibitors acts in synergy. They act together actually. How they act together? Here we can see in one side of the slide it's beta blockers, on the other side they are AC inhibitors. So beta blocker does beta 1 receptor inhibition and AC inhibitors does inhibition in angiotensin 2 as well as activation of bradykinin. So beta blockers via beta 1 receptor inhibition decreases cardiac output and decreases renin release and thus controls the blood pressure. Whereas AC inhibitors, here we see via angiotensin 2 inhibition and via activation of bradykinin, they reduces peripheral vascular resistance, increase the vasodilation and increase the diuresis, and hence they reduce the blood pressure. Beta blockers controls the oxygen consumption and gives cardioprotection on the other side, and AC inhibitors decreases inflammation and endothelial dysfunction and hence gives cardioprotection. So via this combination we will get both blood pressure control as well as cardioprotection. To the next slide please. So here we can see a cascade of beta blockers plus any AC inhibitors. Single pill combination uses across CV continuum. So here are the cascades of pathophysiology, how hypertension goes towards death. So in this cascade we can see hypertension along with smoking, with diabetes and high cholesterol levels. This further leads to endothelial dysfunction, further leads to atherosclerosis, further leads to coronary artery disease, further leads to myocardial ischemia, further leads to coronary thrombosis, further leads to stroke and myocardial infarction, which further leads to arrhythmia and loss of muscle, which further leads to remodeling and ventricular dilation, and then further leads to heart failure, finally towards death. Now the beta blockers, how they are working in this cascade: via BP and heart rate control, via anti-ischemic effect, via angina symptoms reduction, via prognosis and improvement in MI and heart failure patients, via reversing the cardiac remodeling in heart failure patients, and clinical status improvement in the heart failure patients. So these are the main salient features how beta blockers are working in this pathophysiological cascade. And on the other hand, the AC inhibitors, they are working in this cascade via controlling the BP, and they have a prognosis improvement in hypertension, coronary cardiac syndrome, and reversing cardiac remodeling in heart failure, the clinical status improvement in heart failure. So I guess everyone understood the slide. To the next slide please. So not all AC inhibitors are same. So here the perindopril stands out as a hero. How? So here is a comparison of enalapril, lisinopril, ramipril and perindopril. All the group of AC inhibitors are here. So here the trough to peak ratio, let us focus on this. So in enalapril we see 40 to 60 daily, whereas in perindopril it's 75 to 100%. Duration of action in enalapril it's less than 24 hours, in lisinopril it's 24 hours, in ramipril it's 12 to 24 hours, in perindopril it's 24 hours. The trough to peak ratio is it is very good here in perindopril. Bioavailability is pretty good, that is 66%. Lipophilic index is also good, the Tmax is 3 to 6 and terminal half-life is 30 to 120. Okay, to the next slide please. Perindopril 24 hours action with a proven CV protection. Here the trough to peak ratio TP ratio is 75 to 100%, whereas in Remipril it is 50 to 60%. The withdrawal of this medicine due to cough reflux is 3% here in Perindopril, whereas in Remipril we see dry cough in patients, it is 11%. The reduction in central aortic blood pressure, it is 3 plus, whereas there is no established data with Remipril. The easy of dose titration, single step 2 milligram, 4 milligram and 8 milligram OD dose, whereas in Remipril we see 1.25 to 2.5 milligram, then 5 milligram, then 10 milligram in BD and OD dose. In few studies like ASCOT, Advance, HIVET and Progress in Europa, here there has been an established CV protection in hypertensive patients with Perindopril, whereas with Remipril it is still unconclusive. The endothelial apoptosis prevention, we see clear benefit with Perindopril, and also with bradykinin angiotensin selectivity ratio we see a superior benefit with Perindopril in comparison to Remipril. So to the next slide please. Okay, Perindopril mortality benefits established in multiple meta-analyses. So first, here we see in hypertensive patients there is a 13% reduction in all-cause mortality with Perindopril. In high-risk patients there is 28% reduction in myocardial infarction with Perindopril, and patients with a history of acute coronary syndrome there is a 30% reduction and a 5-year mortality with AC inhibitors. So there has been established benefits in all the groups as we can see here. So to the next slide please. So this is Perindopril evidence across CV continuum from hypertension to heart failure. So here are in different pathophysiological conditions there has been few trials. We will not go so deep into this. Okay, so shift to the next slide please. Bisoprolol and Perindopril single pill combination, 24 hours BP control including early morning surge. So basically it's a once a day formulation that works 24 hours. It's Bisoprolol half-life is 10 to 12 hours and Perindopril half-life is up to 17 hours. And for those patients with hypertensive with CV risk, so here what Servier brings to us Cociril with scorable tablets 5x5 and 5x10. Okay, to the next slide please. Opti10 trials sub-analysis, 9 out of 10 hypertensive patients with CV risk achieved BP goals in 10 weeks. So here we can see that it's a prospective multicenter study with 990 Serbian patients, where grade 1 and grade 2 hypertensive patients, those who are having CV risks, 39% of them were diabetes, 7% had coronary syndrome, 7% had a history of MI, and 5% with renal disease. So BP control rate has been achieved at the end of 10 week, 86.5%. So this is pretty good. To the next slide please. So this is a PRIDE study where there is a reduction in 25 mm of mercury in systolic blood pressure in hypertensive patients with a stable CCS and history of MI in 3 months. This is an ambidextrous observational multicentral study that has been conducted over 504 Russian patients with hypertensive and stable CCS and a history of MI. For 3 months this study has been conducted, where we can see that the systolic blood pressure, there is a significant reduction from 148 to 124 mm of Hg, and in all patients there is a reduction in diastolic blood pressure from 87 to 75 mm of Hg. So this clearly shows that within 3 months has been a significant reduction with this combination. So to the next slide, please. 96% patients achieved BP goal in 3 months. So here we can see after initiating this combination, 69 point in week 4 there has been a significant 69.8% of reduction in BP, and at the end of 12 weeks there has been 95.9% reduction in BP, which is pretty good actually. So angina attacks and nitrate consumption decreased by 52% and 73% in 3 months. Number of angina attacks per weeks has been significantly reduced from 4.19 to 1.99 in 3 months, and number of nitroglycerin consumption per week has been lowered from 3.5 to 0.95. So here we can see that there has been an added advantage for those who have had angina attacks in the past, and also those who have been on nitroglycerin. To the next slide, please. Perindopril plus beta blockers, 27% reduction in CV mortality in over 29,000 patients. Data followed up for 4 years. The retrospective pooled analysis in Advanced Europa and Progress trials, over 29,463 patients with vascular disease. The primary endpoint is composite of cardiovascular mortality, non-fatal myocardial infarction, and stroke. So here the blue colored dotted line, we can clearly see that with beta blocker and perindopril combination, there has been the lowest cumulative incidence in 4 years. To the next slide, please. Now the single pill combinations, a step towards improving adherence, because patients are often non-adherent to take multiple pills at given time. So it is better to give a single time at a fixed time of the day, preferably in the morning, and they will be adhered to this taking timely medications. So the European Society of Cardiology guidelines, here is a recommendation that in patients receiving combination BP lowering treatment, a fixed dose single pill combination treatment is recommended. European Society of Hypertension guidelines says that prefer any single pill combination at any step. Next, start with dual combination therapy in most patients. Start with monotherapy only in selected patients. Those who are low risk hypertension and BP is less than 150 over 95 mm of mercury, or high normal BP and very high CV risk, or frail patients and or in advanced age. The WHO guidelines next says that those without CVD but with high CVD risk and diabetes, CKD, and those who are having systolic blood pressure over 130 to 139 mm of mercury, but only if it does not delay the treatment. Combination therapy should be initiated to improve the adherence and persistence. Combination therapy recommended, preferably a single pill. The Indian Society of Hypertension guidelines say that ideally single pill combination should be given. Step 1, dual low dose combination, and so on accordingly. To the next slide, please. So basically in the previous slide what we saw that all the guidelines, those are European Society of Cardiology, European Society of Hypertension, WHO, as well as the Indian Society of Hypertensions, they all have recommended to initiate with a SPC, single pill combination. So to this slide, bisoprolol plus perindopril single pill combination, 1/3 of CV hospitalization, better medication adherence we can see here, reduced risk of CV hospitalization we see here. So this is basically a retrospective observational real world analysis based on some administrative databases that has been conducted over 4,688 patients on a single pill combination of bisoprolol and perindopril monotherapy, and they had been followed up for 1 year. So where we see that if previously there has been a considerable amount of percentage in the increase in adherence, as well as there has been a significant decline in percentage for those patients who had a risk of CV hospitalization after giving this single pill combination. To the next slide, please. So here are some key benefits. Hypertensive patients with stable chronic coronary syndrome and a history of MI, like as here we see in this slide, a patient who is an elderly patient actually, who is having a BP 150 over 90 mm of Hg, heart rate is 80 bpm, history of MI with diabetes and dyslipidemia. So amplifying the benefits of bisoprolol by giving this combination, single pill combination. So here we see in systolic and diastolic 25 and 12 mm of mercury reduction in BP after initiating this combination in 3 months. There has been a significant CV mortality as well in more than 29,000 of patients data. There has been 30% reduction in CV hospitalization, and the plus point is that it is truly a once a day formulation. Okay, to the next slide, please. So this slide shows how arginine salts has an enhanced stability with bisoprolol. 4 mg of perindopril arbutamine is equivalent to 5 mg of perindopril arginine. 8 mg of perindopril arbutamine is equivalent to 10 mg of perindopril arginine. Here we see the molecular weight is also more. Okay, to the next slide, please. Okay, that's finished. Okay, so thank you everyone. I guess I was able to elaborate and discuss the slides and make it everyone easy to understand, and the key to a better BP control, as well as for those patients who have a CV risk, as well as renal risk, as well as a reduction in all-cause mortality, and for those with specific mortality reductions, like for those patients with stroke and acute MI. In all the cases of patients, we are seeing that this single pill combination, that is beta blockers, bisoprolol and perindopril combination, has been showed a clear winner in controlling this hypertension. Thank you everyone.
Sir, there is one simple question in chat box. Can I read it?
Yes, sure.
Sir, one question is how your clinical experience to use this combination means for this?
My clinical experience has been pretty good using this. I have initiated this since last few months, and for those patients, and especially to the patients who are having who are taking even 2 times a day BP medications, and for those patients especially who are having high heart rate, for those patients I have seen there has been a significant reduction in heart rate as well as the blood pressure control. And yes, definitely this combination is one of my choice.
There is no question is there in chat box. And thank you, sir, for your wonderful presentation. And that's all from my side.
Thank you so
Thank
much.
you, sir. Good night, sir.
Thank you. Okay.